Alrighty, guys, how y'all doing? It's going to be chapter 36, chest trauma. We're going to be going over a little bit of chest trauma. You guys can come back to this video, and if you guys have any questions or anything like that, you guys can definitely come back and see this video. Let's see. Intro. So, annually, thoracic trauma cases, you have 880K plus emergency department visits. 35% of them are all trauma deaths, indicating here from the chest trauma. 1 in 4 trauma deaths are due to your thoracic injuries. A&P and psychology review. You have your body cage right here. You have your clavicle on the very top, all the way down. You have your rib cages. You have your suprasternal notch, your angle of Louis, body sternum, your xiphoid process, and right here on the left lung, you have your heart, your lung, your pleura, and even your diaphragm. You have your scapula on the very back on the posterior side, and then your ribs. You have your intercostal spaces right in here, in between. We're going to be talking about needle decompression along the line, and we're going to see where we're going to be doing our needle decompression. So for your diaphragm, attached to the lower 6 ribs of the anterior thoracic cage, size dimension of thoracic cavity varies during ventilation. You have all the muscles here as well. Okay, let's see. Primary psychological functions are to maintain oxygen and ventilation plus your circulation. Underlying medical condition, minimal interruptions through injury can cripple and compromise the system. Let's see, your patho. From traumatic injuries, you're gonna have any traumatic injuries, you're gonna have anything that compromises right here. Ventilation, oxygenation, and circulation. Blood trauma may lead to fractured ribs, which can indicate what? Your float chest, your 2 or 3 ribs floating. You might also see some paradoxal movements. You might have some bruising of the lungs and heart, your lung contusion, your cardio contusion. Damage to the aorta, messed up aorta can lead to like an aneurysm, blowing up your AAA, anything like that. If you have a damaged aorta, more than likely your patient is going to be dead within minutes or even seconds. You have your broken ribs lacerating interthoracic organs. You have your ribs that can puncture your lung, can puncture your liver, can puncture your heart, can cause a cardiac tamponade. Organs torn from detachment as well. Blast injuries. We have talked about the blast injuries already. You have your primary shock wave. Your eardrums, your blown lung. Secondary shock wave can be your penetrating trauma. Anything that's debris, any shrapnel can cause a tension pneumo if it actually punctures. Open pneumo, actually. You have your thoracic trauma, impaired cardiac output, your cardiac tamponade, decreased blood pressure, and perfusion to vital organs. Remember, your cardiac tamponade is the sac around that gets torn. That sac that gets torn is not good. Let's see here. If you have that pericardial sac that's around and it's protecting that heart, and it gets torn and it starts filling up with fluid, well, guess what? That heart is not going to be able to pump adequately. And when that is going on, that's not good. Why? Because your heart is going to get stressed and it's not going to be able to push out the ventricles. Your cardiac output is going to slow down. Blood pressure is going to get lower. No good. Patient's going down. Heart's going to give out too much pressure in the heart. Ventilatory impairments can be rapidly fatal. Shallow breathing reduces minute volume. Sorry, I said value. Shallow breathing, you guys should already know. If you see any shallow breathing, positive pressure ventilation is the way to go. Air entering your pleural spaces compresses the lungs and decreases tidal volume. Pneumothorax. We already know we have negative pressure to be able to contract into your lungs, right? Your diaphragm contracts and it creates negative pressure. That way, the lungs can expand, right? But if we have air into that pleural space, you don't have negative pressure anymore. Now you have air within that pleural space, and you cannot extend that negative pressure. That lung cannot expand. Therefore, you have a pneumo. If you have a tension pneumo or an open pneumo, that means that their air is entering that pleural space as well. There's differences. We also have a blood collection prevents for full lung expansion. A hemopneumothorax, blood in the lung cavity as well. There's different types of pneumos. Let's see, I can't even say that word, but reduces area for gas exchange. I know I had mentioned it in the previous video, but it always messes me up. Sorry, guys. Bruised lungs tissues may cause hypoxemia, your lung contusions, tearing or rupture of respiratory structures prevent O2 from reaching the alveoli. And you remember, the alveoli sacs does the gas exchange. If we have bleeding micro tears because we have a lung contusion, do you think you're able to do that gas exchange? No, you have blood in there. More than likely, it's going to get compromised, and that's where you're going to see your hypoxemia kicking in. Patient assessment. If you already know that you're dealing with any chest injuries, go out there and see. Be sure you're seen as safe. What if a horse, kicks somebody in the chest? What if it was a baseball bat? What if it was a baseball? What if it was just somebody fighting and gets hit? What if somebody's running? Those funny videos when somebody's running and they hit a pole. What if it was something just out there? You have to make sure, is your area safe or not? Always follow your standard precautions. Be a sizing safe. Identify number of patients. If it's just one patient, awesome. All right. Would you want to call additional resources? Yes, I would. Especially if it sounds pretty bad, I would. Form a general impression, guys. Assess the level of consciousness. Ooh, hold up. This thing moved on me. Assess the level of consciousness. General impression. Look at your patient. Is your patient clutching his chest or her chest already? Did an ATV roll over? Something like that. I know in East Texas there was a things where they will go mudding all the time, and a lot of ATVs, a lot of side by sides. I had a lot of females and males that would always get run over. They were going into the mud. They would go and everything. They would flip, and the thing would always land on them and right on top of them and in their chest. And I had some lung contusions, cardiac contusions that I was able to follow up on, and they had that. So it's good. You might see some EKGs later on down the line in your second semester, but you're gonna notice that some of the EKGs might have some abnormalities as well, especially if they got crumbled. But look at your general impression, assess your level of consciousness, assess their entire body. Remember, like that little usual saying, a trauma patient is a naked patient, right? Cut, assess, cover them up, treat for shock. Observe the neck for accessory muscle use, distended or engorged JVD. Remember, you have your JVD right here. If they're using a lot of their muscles, that is not good. What is going on? Let's try to find the issue. Focus on your airway, breathing, circulation. Assess while performing spinal mobilization if it's needed, right? If it's a messed up call, if you already know, hey, let's put that seat collar on. Okay, who's in charge of moving the patient? It's always the one in the what? In the head. They call the shots. 1, 2, 3, move. Check the back, check for the neck, check for step down, things like that, right? Let's see. Patient's clothing must be removed to expose the thoracic cavity. Cut. Look, check, feel, and then auscultate as well. Auscultation goes a long way. The stethoscope should not be in your backpack. Palpate the patient's neck for tracheal deviation. Inspect if jugular veins are distended or flat. Remember, if you have tracheal deviation, that is a very late sign. Tracheal deviation is a late sign, guys. So watch out for that. But let's say we do have a messed up lung, right? Let's say we do have our little we have our lungs, right? Your right lung and your left lung. And let's say your left lung collapsed. On my side is my left, right? where are you going to see that trachea? Is that trachea going to go to my right or to my left? It's not going to go to the collapsed side. I'll tell you that much. No go. It will always go towards the good lung. When you have tracheal deviation, that trachea is going to go to the good side of the lung. It's stingy. This lung is stingy now. It wants that good air. So this trachea deviation is going to be pulling to the good lung. Whenever you do have trachea deviation, always know this is not a good sign. Okay, you found it, awesome, but doesn't mean that your patient is doing good. Your patient is not going to do good at all. You have that tracheal deviation, and if it's the tracheal deviation is going to my right, that means to the right is my good lung. If it's going to the left is my good lung. So more than likely, the opposite of that side, your lung, you probably are dealing with a tension pneumo or a pneumothorax. Like a very, very late sign though. Very late sign. Let's see. Begin the thorax inspection by checking the contour, the appearance, the symmetry of the chest wall. I've seen some people, flight medics that I've had gotten like chest trauma injuries, and they go and they actually inspect. They go and they touch all the way, and they inspect when they're taking a deep breath. Why? I've asked why before, and they say they want to see if there's any differences first. Yes, they're feeling, but they want to see if there's any messed up compliance, I guess. That's the way they said it. They want to see if there's some compliance or if there's any mismatch. They were feeling, I guess, for that paradoxal movement. And make sure you have that symmetric if you want that. Why? Because if you have paradoxal movement, it's not good. It's not a good sign. Signs of underlying injury with potential to compromise breathing. You have your soft tissue injuries, like I mentioned, your paradoxal movement, your retractions, patient breathing really, really hard, subcutaneous air or edema, impaled objects, any impaled objects in the chest area, leave it be, never take it out. The only time is if you're going to perform CPR, take it out from the chest, start doing CPR, but look at the signs. Look at your signs. If there's obvious signs of death, call it. Any penetrating objects, stay in plane. Stay in plane there. Never take them out unless it's in the airway. But other than that, don't mess with it. Assess ventilation and oxygenation. If your patient has shallow breathing, positive pressure ventilation. Never go straight to intubation. Positive pressure ventilation. Remember, basics before paramedic. Basics, always basics. Even the National Registry, you're gonna get questions like this, and I'm pretty sure one of these answers intubate. No, provide positive pressure ventilation first. Always start basic. You could even start with a non-rebreather mask if that condition is within suitable with that. Apply O2, 15 liters per minute with a non-rebreather. Evaluate skin circulation. Look at your patient. Decreasing O2 saturation may indicate hypoxia. Watch for impending tension pneumo. When you have really bad absent breath sounds, things like that. Okay, what is going on? What is going on? Palpate for your point tenderness, bony instability, your crepitus, subcutaneous emphysema. We should know what these all are right here, especially crepitus, subcutaneous emphysema, and edema. You're going to palpate for all these things. Look, see, feel, hear. Percuss for hyperresonance, your dullness, auscultate for adventitions lung sounds, confirmation of lung sounds. Adventitions is another word for abnormal lung sounds. Abnormal lung sounds. Percuss, you actually can hear the lung and you can like tap it. And if it sounds like a drum, it's dull. A little dull. A little dull. Assessing the quality of a pulse should help determine hemodynamic stability. Clue for your clinical findings of a cardiac tamponade. Is your patient hemodynamically stable. Let's call it there. If you have a pulse, a radial pulse, okay, my systolic blood pressure might be above 90%, right? I mean 90%, 90 systolic. Now, if you have an absent radial, but you do have a weak carotid, okay, what is going on? My patient might be hypotensive. That is not a good sign. Look at all the clinical findings. Suspect cardiac tamponade as well. You might have something called Beck's triad, muffled heart tones, hypotension with a high heart rate, things like this. JVD is a good one as well. JVD suggests intravenous pressure measures in 45-degree angle in semi-Fowler's position, and you will see this. Boom, go back and forth, back and forth, back and forth. Another one too, where you want to confirm, you can press right here on the liver. You can go to the liver, just palpate just a tiny bit, and you're gonna see this. So it will come out if you press just right. Auscultate the heart. Note if the heart sounds are easily heard or muffled. Like I've mentioned, cardiac tamponade has that muffled heart tones. But you want to hear, okay, how's my heart sound? Does it sound regular, like you're little lubbed up, lubbed up, lubbed up, you know, tum tum, tum tum, tum tum? Or does it sound a little abnormal or maybe a little muffled? Can't really think of anything right now, but maybe we can go to YouTube and look for a muffled heart tone. But if shock suggested, may not be from the thorax. Obtain history and complete your physical. Transport decision. Prioritize your patients with ABCs. You guys should already know that. A, B, C, D, E. You know, all those good things. If signs of poor perfusion or inadequate breathing, transport quickly. Do not delay for IV. Do not delay for this. Do not delay for that. No, you can do all those things en route. Don't forget that. Perform an assessment en route. En route. History taking. Maybe need to done en route. En route. If your patient is not good, en route. Obtain relevant patient history. You have your sample. Questions about event should be focused on your mechanism of injury. What happened? What were you doing? Things like that. MOI. Full MOI. Secondary assessment. Head to toe. Check for injuries that may compromise your ABCs. Obtain full set of vitals. Monitoring equipment can aid your assessment. Remember, head to toe. DCAP TLS. A patient, trauma patient is a naked patient at this point. If you have some sort of messed up trauma, cut. Assess. DCAP TLS. Look, hear, feel, whatever it is. You know, deformities, contusions, abrasions, penetrations, burns, lacerations, tenderness, swelling as well. All that good stuff. Don't forget. And always obtain your full set of vitals. Your vital signs go a long way, guys. Know what to look for in your vital signs as well. If you have a patient that is not doing too good, do you think your vital signs are going to be, oh, my patient is trying to compensate. More than likely, my vital signs are going to be up. No biggie. Then you get your blood pressure, your heart rate. Your heart rate is at 60. Your blood pressure is at 90 below systolic. It's not good. What are we going to do? You know, what is your plan of action type of thing? Monitoring equipment can aid this assessment. What monitoring equipment? Your SpO2, your cardiac, your monitor, your cardiac, your ECGs. You also have your ETCO2. If chest injury is isolated with limited MOI, focus on your isolated injury, patient's complaint, body region affected. If it's just isolated, okay, good. Focus on that and then move on. Focus, move on. If significant trauma assesses head to toe, your skin, you have your ecchymosis, any sort of bruising. Identify all wounds and control your bleeding. As you find the wounds, treat right there. If you find somebody that got shot in the chest, you're gonna cut, assess. If you see a sucking chest wound, the first thing I want you guys to do is use your glove hand, stop that bleed right there. Get an occlusive dressing and work your way from there. Work your way from there. Don't be, oh, I'm gonna start IV right away and give TXA. There's a little thing, there's little by little. Remember, Remember, gloved hand first. We go to basic. Don't forget your basics. We always go to basic first. Well, gloved hand, stop that sucking chest wound, occlusive dressing, tape it 3 sides, and then we'll work our way from there. Why? We're still going to look for other injuries. Don't just get distracted if it's right here. No. What if it was a woman? Look right here on the other armpits, under the breast, look on the other side, look at the back, everything. Everything. If significant trauma affects multiple systems, perform your full body scan, inspect all regions, inspect the regions for deformities, palpate for tenderness, check for lacerations and swelling. Full decap BTLS. Obtain your repeated assessment of vitals, oxygenation, the breathing sounds, your breath sounds, and your circulation. If pneumothorax is suspected, patient should be considered unstable. Maintain a high degree of suspicion. Auscultate, auscultate, auscultate. If you have an absent lung sounds, okay. And if your patient's still there with it, they're not ultramental status yet, awesome. You're just suspecting a simple pneumo. Okay, non-rebreather. But if once they start showing signs of ultramental status, mild hypoxia starts kicking in, okay, that's positive pressure ventilation. Positive pressure ventilation. Emergency medical care for this. We have different types. Management focuses on maintaining your airway, ensure oxygenation and ventilation, supporting your circulatory status, and expeditious transport. By supporting circulatory status, starting your IV, make sure your blood pressure is within range. You want just that 90 systolic above your MAP of 60, ensuring your oxygenation and ventilation is good. You want what? SpO2 above 94, EtCO2 35 to 45, things like that. Airway management exam, same, except for your jaw thrust maneuver instead of your head tilt chin lift. If you have trauma, always remember, no head tilt chin lift, jaw thrust maneuver is the way to go. Avoid any nasal airways if signs of your facial injury. ET intubation is dead. Full intubation, ET, endotracheal intubation. But remember, what type of facial injuries can we worry about? Le Forte fractures. We have Le Forte 1, Le Forte 2, Le Forte 3. You have to watch out for all these type of fractures. Ensure oxygenation and ventilation is given adequately. Assess circulatory system ability to provide oxygenation and ventilation. Everything. Make sure your patient is breathing. If not, your partner is going to breathe before them or you're breathing for them. Bag them. Positive pressure ventilation. It doesn't hurt. It's okay. But if you guys need to take over the airway, okay. By all means, if they're unresponsive already, awesome. Go for it. If not, pharmacologic agents are limited. Medications for airway management or even pain management, limited by your local protocols and clinical states. If your patient's already unresponsive in a very bad trauma call and they don't have a gag reflex, is there a need for RSI? No. Now, there's different types. If your patient's still responsive or you put the OPA in there and they start gagging and the patient's not looking good at all, okay, do you want to take over the airway? Fine. If your protocol insists, RSI measures, you should go for your RSI if that's the way you want to go. But remember, everything there is within your protocols. Pain management, the same way. Same way. If your patient is having trouble breathing because they got shot on the lung, okay. If you want to give them morphine or fentanyl, that's completely fine. You have your EtCO2 to monitor. Just remember, monitor the EtCO2. Why? Because any pain medication also messes up your respiratory drive. So you don't want to mess up their respiratory drive. That's the thing you have to watch out for. If you give them some, make sure you're within range and talk to your patient. Sir, ma'am, how are you doing? How's my EtCO2 levels? Don't forget to try your best to take a deep breath. Remember, if they got shot and they have a messed up trauma in the chest, it's already going to be hard for them to be breathing. So if you already have not taken over the airway, it's one of those things that you're going to have to tell them, hey, take a deep breath, whatever's going on. If not, guess what? RSI it is. Non-pharmacological approaches, we have splinting your injury, cold plaque application, careful handling. Remember, if somebody gets messed up, you can splint. That's fine. You can do the cold pack application, careful handling, all that good stuff. We are good. Basic before ALS, BLS before ALS, BLS before ALS. We have your appropriate facilities. Here in the Valley, you have Valley Baptist nearby. That's considered level 2 trauma center. And we have DHR over there in that other side. And DHR is considered, I think, a level 1. So, if you're within those ranges, good. McAllen Medical is also in what is it, like the south side of McAllen, I guess you can call it. And they're also a level 2 trauma facility, and they're very good. You don't want to take a trauma to McAllen Heart Hospital. They're gonna be like, "What are you doing? This is not even a STEMI." But then, they'll tell you stuff. But they're a regular hospital; they can take anything. Wink. Principle of golden period, golden hour. We have 1 hour to get to the hospital to the patient on the surgery table. Prep them basically. So you're supposed to be how many minutes on scene? 10. You're supposed to be 10. And then you got basically 50 minutes to get there. Everything is critical. Your report is critical. Now we have Pulsera, and they have a little picture thing. I know I've used it before where something is like really messed up, and I'm like, man, I can't explain this, but here you go. That's what I'm dealing with. And they're, oh, okay, that's fine. I'll see you upon arrival in trauma, whatever. And that's the way you can go. Alrighty. Flail chest may result from your blunt force mechanism, 2 or more what is wrong with me today? 2 or more ribs fractured in 2 or more places. You have your broken ribs right here. And remember, that causes what? Paradoxal movement. There's different things. Flail chest is your 2 or 3 messed up ribs. Location and full size degree that the chest wall of the air movement are impaired. That's where you're going to have your flail sternum most extreme. You'll see the differences. Underlying pressure can cause paradoxal movement and segment of the right of chest wall. Now, this is your paradoxal movement, but you are having your flail chest. Remember, flail chest is your 2 or 3 broken ribs. Paradoxal movement is back and forth. Go hand in hand. May not be initially apparent. Sorry. Popping for rib cage fractures and crepitus. Remember, do your assessment. You don't want to do biscuits. You don't want to be like a cat, purring. No. You want to get in there, you're going to feel. Once, you're going to see how it feels. The patient's going to be screaming more than likely. Management may involve positive pressure ventilation. Positive pressure ventilation. Positive pressure ventilation, guys. And then we have positive and expiratory pressure as well. Pulmonary contusion can also be caused by blunt force trauma. Your mechanism is your implosion and inertial effects, Spaulding effects. Any of those can cause a pulmonary contusion, a bruised lung. Remember, with a bruised lung, you're going to have micro tears, and those micro tears are going to bleed within the alveoli, and it's going to not do the gas exchange properly. So SpO2 levels might be a little off. So that's where you have to watch out. You have to watch out for those things. Pneumo or hemopneumothorax may occur if bone fragments are driven into the body. Pain may prevent adequate total volume. Remember, if you have broken ribs and they're already floating around and there's bumps going, everything is messed up, and all that stuff, patient, you might see a different type of end-tidal CO2, right? They're going to be hurting, and you're going to see different types of waves. Well, would you give pain management for this? It hurts, yes. Hopefully try your best to calm it down, right? Because they're just like, they don't even want to breathe. And okay, relax them a bit. Give them morphine or fentanyl, whatever you guys decide, whatever your protocol say, go for it from there. Relax it. Remember, what's supposed to be our total volume? 500 mLs, right? How much do we use? 350. How much is in the dead space? 150. But if that occurs, pneumo or hemopneumo, are we really using that 350? No, we're not. Assess and manage. Palpate may reveal your crepitus, tenderness, dissection of air. Auscultate may reveal decreased or absent lung sounds. That's what I'm saying all the time. Um, auscultate, auscultate, auscultate. Because right there, when you guys are getting questions for this, this is going to tell you, oh, I might have a flood chest or a pneumo or a tension pneumo or anything that's going on. You might have your decreased lung sounds or your absent breath lung sounds. Always carry your stethoscope and always auscultate. Always auscultate. Signs and symptoms are also going to include your hypoxia, your hypercarbia, pain, and associated findings is going to be tenderness, shallow breathing, and tachycardia. Hypercarbia would be what? High EtCO2. So that means you're going to have shallow breathing. Shallow breathing. Remember, high EtCO2 is the opposite of the respiratory, shallow breathing. And then now we have hypocarbia. What is going on? We have hypocarbia. We're going to have the respiratory rate high. Remember, it goes different. This is also in respiratory emergencies. Assessment and management. Pose a threat to the patient's ability to breathe. Intubation and positive pressure ventilation are indicated. If your patient is ultramental status at this point, hypoxic, take over the airway. Take over the airway and then intubate. But remember, first, positive pressure ventilation, and then get ready for your intubation. Goes SpO2 of at least 95% with supplemental oxygen and positive pressure ventilation. Most common thoracic injuries, the pain contributes to inadequate ventilation, self-splinting, atelectasis, the lung breakdown, I believe it is, pneumonia from inadequate respirations. You have it right there. You can see the broken ribs. It should be on your book. Palpate the chest for subcutaneous emphysema. Remember, subcutaneous emphysema, it's those little Rice Krispies, the little bubbles that you're going. It sounds kind of like a little tap, 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 tap. You're going to see pouches maybe of white. Blunt trauma may also result in fractures of the point impact, the edge of the object, or your posterior angle of the rib. Any of those things that does fracture, okay, you have to watch out. Do we know exactly what fractured? No. Do we know where the locations are? Yeah. So be on the lookout for that. Okay. Your rib fractures may indicate associated injuries from your ribs 4 to 9. From ribs 4 to 9, you could have an aortic injury, tracheobronchial injury, pneumothorax, or a vascular injury. From ribs 4 to 9, these are common injuries that you see. Aortic injury, tracheobronchial injury, your pneumo, or your vascular injuries. Now, if you have your ribs 9 through 10, abdominal injury, intra-abdominal. Those are the ones a little bit more on the bottom that can hit your intestines. And the ribs 4 to 9, a little bit more above. Assessment and management for your rib fractures, pleuritic chest pain, mild shortness of breath. You know, they're gonna, they're gonna probably be guarding. They'll probably be guarding for sure. Exam may reveal chest wall tenderness, soft tissue injuries, crepitus, subcutaneous emphysema. Management, evaluate your ABCs and also evaluate for other injuries. You should already know. If it's just a chest injury, don't focus on the chest. Look for other injuries as well. Administer O2. You guys already know this. Start basic. O2, non-rebreather. Unless your patient has shallow breathing, positive pressure ventilation, and then we will take over airway if you decide to do that. Gently splint the chest wall. Consider IV analgesics. Now, gently splinting the chest wall has been one of those things that they tell you, put like 2 Kerlix and just tape them. That's actually been outdated. So you have to make sure, don't do anything there. I'll just leave it in place. Even though it says gently like splint, I think by what that means is if you have like an open pneumo, just put your occlusive dressing. That's it. I'm trying to see if there's anything here on the book for that, but I don't see any gentle splinting. And then obviously IV analgesic, I know I went over it. pain management. Analgesic means pain management. Okay, and the medication that has analgesic effects to make you forget, about pain. Sternal fractures, suspected fractures of the sternum should increase suspicions for injuries to underlying organs. Right there. What do we have here in that sternum right there? We have our heart, we have our lung. Assess and management, pain over the anterior part of the chest. Palpate may reveal the same thing. Tenderness, crepitus, possible flail segment. Do we know exactly on the ribs? Yes. But what about the sternum? Yeah, you can feel. You know the locations, but are we dead on sure? Oh, it's the sternum. No, but you can feel. You can feel. No, we don't have X-rays. We can just go for our assessment, everything that we're seeing. Perform an EKG rhythm analysis, supportive treatment only. ABCs, manage your ABCs, associated injuries as well. Analgesic medications. Why do you think we want an ECG monitoring? You want to see if that injury, that sternal injury, hit the heart. You can see those rhythms. You can see when the heart is failing. One of the most common fractures, your clavicle fractures, guys. Right there in the very top. I myself had one. It sucks. Assessment and management. The patient will report pain in the shoulder. Usually hold the arm across the front of the body. Depends how you get it, but usually you can be guarding. That's it. Remember, they broke this, so can they move the elbow? Yes. Remember, they broke the shoulder right here on top. So just watch out for that. Consider your splinting skills might come into play. There's different ways to splint this one. You've used the sling and swath, or there's another little method where you can actually tighten up the back and it stretches out that clavicle and it's not hurting. It takes a little bit more time, but yes, it's there. Assessment, the same thing. Get your vitals. IV analgesics provide pain relief during transport. Why? Those bumps hurt. Anybody that has suffered from a broken bone knows those bumps hurt. That's the one that hurts a lot. Splint fractures with a sling and swath. Apply gentle upward support to the olecranon process of the ulna. Knot should be tied on the side of the neck. Right here. If I broke up this one, right here. Simple pneumo. Accumulation of air and gas in the pleural cavity. Air enters through a hole in the chest of the wall lung. Sorry. Air enters through a hole in the chest, wall, or lung. Air enters through the collapse. It causes the lung to collapse on the affected side. Sorry, I had a little brain fart there, guys. I was spinning a little bit. So remember, we have our lung, we have our peripheral pleura, the little surfactant there as well, right? Here you can see the little air. I'm pretty sure if you have your book, you can see it there. Assessment and management. Small pneumothorax, mild shortness of breath, and pleuritic chest pain. Diminished or unequal breath sounds. Hyperrenaissance. Larger, oh my God, I said it. Thank you. Larger pneumothorax, increasing shortness of breath, signs of a serious respiratory compromise, and hypoxia. So there's different ones. You can start with a simple small pneumothorax, and usually the ones that have this is your tall, white, thin males. Tall, white, thin males are the ones that are right here. Questions that you get mostly all the time with a simple pneumothorax, tall, white, thin males. And this is what usually you're going to see. Your signs and symptoms that you might see is right here. And if it's getting worse and worse and worse, it's going to lead to your larger pneumothorax and signs of serious respiratory compromise and hypoxia. Once it leads to this, positive pressure ventilation. This on top, non-rebreather. Non-rebreather, 15 liters per minute. Or once your patient starts going down, signs of serious respiratory compromise and hypoxia, positive pressure ventilations. Know the differences. Know the differences. Maintain your ABCs and provide high concentration of O2. Conduct repeated assessment. Rapid recognition and management can be life-saving. First, remember, it starts with a simple, and then it goes to a bigger one, and it gets worse and worse and worse. So you have to keep on looking at your vital signs to see how your patient is doing. Open pneumo. Give me 1 second. I'm gonna take a little bit of water here. Okay. Open pneumo. We have injury right here that actually goes into the lung. Occurs when a chest wall defect allows air into the thoracic space. Results from penetrating chest trauma. Negative pressure draws air into the pleural space. So remember, like we're a balloon, right? We're gonna pull down. When we're pulling down, our lungs are expanding. When we have this, our lungs expanding and air is coming in, and it's going into the pleural space. That lung is already deflated, and all that air is gonna come in here, and it's gonna put pressure. As size increases, the lung loses ability to expand. So the air is coming in more and more and more and more. It's drawing in. The air is just drawing in. What's pushing against that lung? It's going to be pushing against that lung. And then it's going to be slowly causing a more likely a tension. But if holes larger than the glottis opening, air is likely to enter the chest wall. Creates a what? Sucking chest wound. Right there. And I know it sounds funny, guys, but it's sometimes like the ones that I've had, they sound like a wet fart when they're trying to like breathe. You literally hear like sometimes the air is escaping, and it literally sounds like that. So don't be freaking out and be like, "What's going on with my patient? Dirty patient?" No, it's the air is just sucking out. The air is just sucking out. If pulmonary vasculature on involved sides remain intact, heart will continue to perfuse the collapsed lung. Pneumothorax prevents ventilation. So that's where it can get a little confusing sometimes. If pulmonary vasculature on involved side remains intact, heart will continue to perfuse the collapsed lung, which is good. Which is good. Pneumothorax prevents ventilation. So you just want to be ventilating. Know your assessment on these types of injuries, guys. Physical assessment shows chest wall defect, impaled object, sucking chest wound, bubbling wound, subcutaneous emphysema. Know these things that can happen. Remember, any open injury that you have, you're going to go straight to what? Your gloved hand, boom. Gloved hand, go. It's a sucking chest wound, right? Gloved hand, tape 3 sides. Tape 3 sides and go from there. That is the first thing you do. And then you work your way out, right? You work your way down, look for more, if anything. From that sucking chest wound, it can lead to also subcutaneous emphysema. Why? Because remember, air gets in there. Air gets in there, so be sure to be assessing, if anything. Bubbling wound, the same thing. In the bubbling wound, you're going to see some air coming out. Impaled objects, stay in there. You never take anything out on that. Signs and symptoms may include tachycardia and fast breathing, tachypnea. You're going to see patients get anxious, restlessness. They're going to start breathing a little bit faster. I can't breathe. Your patient starts to compensate. You're going to see your respiratory rate get high, your tachycardic as well. As pneumothorax increases, breath sounds decreases on affected site. You guys are going to auscultate and see. If they're telling you, I can't breathe, okay, auscultate and find out which lung is my affected site. If I don't hear anything on my left one more than likely is the affected one, right? You're going to have your treatment immediately. Convert the wound to a closed injury. Place high flow O2 via non-rebreather mask. Put it right there. Put if you have any seals, awesome, use it. If you don't have any chest seals, use your I literally just said it. I completely forgot, guys. My bad. Use your what is it? Tape it 3 sides. Tape it 3 sides. What is it? Occlusive dressing. There you go. Thank you. Assisted by Justice. Thank you. Occlusive dressing. Tape 3 sides if you don't have a full chest seal. Sorry for that, guys. And place on O2, non-rebreather mask. Simple as that. Once your patient goes down or showing signs of altered mental status, that's when your BVM comes into play. An open pneumo usually doesn't progress to a tension pneumo. Good to know. Now, tension pneumo. That's a good one right there. Know the differences. We have your open pneumo, your simple pneumo, and now we're in tension pneumo. Life-threatening condition from air accumulation within the pleural space. You have your lung injury right there. And then you have your heart, the air accumulation inside, and the lung injury. As air accumulates, pressure builds against the surrounding tissue. Compresses the lung, which diminishes the ability to oxygenate blood and eliminate CO2. If you see it right here, we have that injured lung, and it's like I had mentioned. The diaphragm is just pulling. Well, guess what? It's trying to pull this out, and you're getting pleural space in. That pleural space is pushing against what? The heart. So that is not good. It's just sucking on that heart, and it's not going to be good. If you have that, it's going to lead to decreased cardiac output, decrease in thoracic pressure, or increase in thoracic pressure, and it's going to lead for low blood pressure, low heart rate, your patient's going down. Pressure causes eventual lung collapse and mediastinum to shift. May exceed pressure in major venous structures. If venous return decreases, the body will increase the heart rate. It's compensating. It's trying. Assessment and management. Classic signs may include your absent breath sounds on affected side, unequal chest rise, pulsus paradoxus. Remember, what is pulsus paradoxus? Whenever you're telling your patient, take a deep breath, you're checking their pulse, and the pulse stops when they're taking a breath for about 10 seconds. That is a positive sign for pulsus paradoxus. We have our tachycardia. We already know what VFib is, or we should. JVD. We have our narrowing blood pressure right there, or your narrowing pulse pressure, and then you have your tracheal deviation. We should know these already. Change is induced by tension pneumo, inability of blood to easily return from the heart from the venous system, increasing pressure within the thoracic cavity. Veins become distended with blood. During normal inspiration, you have your negative pressure decreased blood return, and your preload and your systolic blood pressure decreases. Basically, like I've been mentioning all along. If you have positive intrathoracic pressure going into the lungs, if there's so much pressure going into the lungs, well, what's going to happen to the heart? It's going to get pressured. And that is not good. Why? Because you're pressuring the heart. It can't be pumping adequately. So that means if you have a decrease of cardiac output, well, that means your blood pressure is also going to drop. Preload and systolic blood pressure is also going to drop. And tension pneumo effect is magnified by your pulsus paradoxus. So whenever you're taking a deep breath, when you have this, that pressure is actually contracting, it's pushing against the heart really bad that it reduces the cardiac output that you cannot even feel the pulse going because it's decreasing that cardiac output so bad that it's just trying its best to stay within what is it? It's trying its best to compensate. I'm sorry about that, guys. Assessment and management may show tracheal deviation from affected side, may show diminished breath sounds. Remember, tracheal deviation is not a good sign. That is a late sign. You may have pleuritic chest pain and shortness of breath. Hypotension is a late finding. That is not good. Patient's going down. You should already be ventilating your patient. You should already be working on IVs and maybe giving them some fluids. Administer immediate high flow O2. Inspect the chest. Cover open wounds with dressings. Your occlusive dressings, 3 sites. Occlusive dressing, 3 sites. If elevated pressure is relieved, needle decompression is needed. So This is where we might need to do your needle decompressions, right? Especially when your patient is not showing signs of good outcome or vital signs. That's where we can do a needle decompression. And let's talk about it. Whenever you do have your needle decompressions, you're going to be going to either your mid sternal, the medium, or the lateral, the sides. For this one, we're going to go into the mid clavicular. We're going to go into the mid clavicular area right here. We're going to gather all our things, right? You're going to see your patient probably paradoxal movement, hypotension, shortness of breath, things like that. You're going to locate the midclavicular line and you're going to go from your second and third. So you have 1, 2, 3. So midclavicular line, and you have your second and third right above the third. Why do you think it's right above? Because you see here, we have veins, we have nerves endings under each rib. So that's where we're gonna go 1, 2, 3, right above the third. And this is money right here. This is where we were going to insert. Second and third intercostal, right above the third, never below. Why? Because below you have veins, you have nerves endings that you're gonna damage if you go below. Always above the third. Second and third, above the third. We're gonna go over those skills on class day. Let's see. I know there's another spot. Let's see. You have your side. Let me see if it talks about it here. Okay. You also have your fifth intercostal. So you have 1, 2, 3, 4, and then boom, right here. Fifth. So that's where this picture has that. So you have your midclavicular line, or if not, you have your lateral side right here. Right under the armpit, right here on the side. You're gonna count. You can guide off yourself from here, the midclavicular. 1, 2, 3, 4, 5, right above. Why? Because below you have your nerve endings, you have veins flowing through there. So right above the fifth, and it's gonna go to the side, right under the armpit. A lot of people what they try to do is just get the whole hand right here under the armpit, and that should be somewhere near the landmark of the needle decompression on the side. But don't just go based off that. Go and feel. Go and feel. But that should be a pretty good indicator. Hemothorax occurs when potential space between the peritoneal and visceral pleura is violated. Blood filled into the pleural space. You have your wound site, everything is bleeding in there. And then you have your collapsed lung, visceral pleura as well. All that blood is accumulating, the air also, so it's a double whammy. That's not good. Well, actually, just a hemo. Sorry. Because there's a hemopneumothorax. So sorry about that. Commonly caused by lung parenchyma tearing. Collection of the blood compresses and displaces the lung. Right there. Perfect example. Everything is just pressuring into the lung. We have our hemopneumothorax, blood and air within the pleural space. That's the one I was just talking about earlier. Massive hemothorax is accumulation of more than 1,500 mLs of blood within the pleura. Can we measure the blood? No, we can't. But if it's a lot, it's a lot. So that's one of the ones that we can be like, ooh, this person has pretty bad hemo. Especially if you see everything just bleeding out. Assessment and management signs include ventilatory insufficiency and hypovolemic shock. Remember, we have to ABCs: ventilate, breathe for them, and then from there, get your IVs in, start going. Patient needs surgery. We have 10 minutes on scene. We have 10 minutes on scene. And then after that, we have 50 minutes. We have 50 minutes to take him to the hospital. They need surgery right off the bat. Findings and management for these types of injuries: lack of tracheal deviation, possible hematosis, which dullness on percussion, flat neck veins with hypovolemia, distended neck veins with increased pressure. You also have supportive care for your pre-hospital management, supportive care, rapid transport, high flow O2, and then right there, bilateral 18 gauges. Bilateral 18 gauges, maybe give your TXA, give pain management if you can, but always have your supportive care going, high flow O2. At that point, maybe if the patient's really, really bad, you might have to control their airway. Pulmonary contusion, alveolar and capillary damage results from the lung tissue, compression against the chest wall. Injury may lead to loss of fluid and blood into the involved tissues, white blood cell migration into the area, local tissue edema. Local surfactant in the alveoli is diluted, causing atelectasis. Delivery of O2 is reduced, causing hypoxia. Attempt to shunt blood from the injury further worsens your hypoxemia. Airway management, or actually assessment and management, may not initially show presence of severity. You have your hypoxia and CO2 retention may cause respiratory distress, shortness of breath, or even high breathing, a lot of breathing, tachypnea, agitation, restlessness, anxious. You might see these type of things. The patient may even have altered mental status. So you might have to just give them some O2. Evidence of overlying injury, you have your contusions, tenderness, crepitus, paradoxal motion. For pulmonary contusion, the big one, these two right here, contusions and tenderness. You might see bulge of purple, red, and very, very tender. Sometimes you might even have your broken ribs. And well, with broken ribs, 2 or more, paradoxal motion might come into play. Auscultation may reveal some wheezing, rhonchi, crackles, and diminished lung sounds. Don't be surprised if you actually are coughing up some blood, and if you can hear these type of things. Why? Because your alveoli sacs just got hit pretty good. Treatment includes managing airway, using caution when administering IV fluids, administering small amounts of analgesics for pain. Remember, you don't want to give too much pain medication because the respiratory drive is already hurting as it is. Yes, you want to relax them, but you don't want to hurt them either. You don't want them to drown in their own blood because that pulmonary contusion is hitting those alveoli sacs. Remember, those alveoli sacs got hurt, they got bruised, they got torn, they're bleeding in those alveoli sacs. So that's not good. You want them to do the full proper gas exchange. You want that oxygen and you want that CO2 to do the full exchange. You can't do the full exchange if there's blood mixed in there. So, pathophysiology assessment and management of your myocardial injuries. We have our cardiac tamponade, excessive fluid in the pericardial sac, compressing of the heart, decreased cardiac output. We should already know this. We already know we have our normal heart right here. But if somebody gets kicked with or hit with a baseball bat, hit with a baseball, hit with the horse kicked them straight on the chest. Now they're having a lot of trouble breathing. It's hurting their heart. Well, guess what? That sac more than likely got hurt. It's bleeding within there and it's causing pressure within the heart. And that can be messing up bad. Why? Because we have hemodynamic effects that can go. It all depends on the rate of the hemorrhage and the chamber of the heart involved. It can be your uppers or your lowers or all around, right? But remember, which one is the strongest muscle of all? I mean, which one of those chambers is the strongest one? The left ventricle. The left ventricle is the one pumping everything back to the blood, to the body. So if that left ventricle starts to get more pressure, they can't do those full push-ups like I've mentioned. Well, what's going to happen? It's going to go down. Cardiac tamponade can occur in both medical and trauma. Medical, slow fluid collection, and trauma, rapid bleeding. Continued bleeding increases pressure in the pericardium. Atria and vena cava is compressed, reducing your preload delivery increase your heart rate to compensate, but could only compensate for so much. It's going, it's doing its push-ups, I can do my thing, and then I'm getting heavier and heavier weights. The heart is a muscle, it could only do so much. 10 to 40 diagnoses will have your Beck's triad. You have your muffled heart tones, hypotension, JVD. Muffled heart tones, hypotension, JVD. That is your Beck's triad. Electrical alternance and EKG strips. You're going to see some abnormalities in your EKG. Findings typical of shock include your weak or absent peripheral pulses, diaphoresis, dyspnea, cyanosis, altered mental status, tachycardia, agitation. Let's see. Your findings are similar to attention pneumo. So just be on the lookout for this. Know the differences. You have your table there that can show you. Let's see. Treatment. Assess your ABCs. Ensure adequate O2 is established by IV access. Provide a rapid fluid bolus. Administer your IV fluids. Rapid transport. We can't do anything here. Before, we used to be able to do something called pericardiocentesis, where you can see right there in that image, it has a little needle. They trained paramedics before where they can actually go into the chest cavity, go into the heart, and draw out the blood. Was it successful? No. Why? They took it away from us for a big reason. We didn't know how far we were going. Some were going too deep, or maybe just didn't do it as often. So that's one of the biggest ones that it got discontinued as a paramedic, unfortunately. Myocardial contusion, the same thing. Sudden deceleration of the chest wall may cause the collision of the heart to the sternum. It's characterized by local tissue contusion and hemorrhage, edema and cellular damage within the myocardium. Your heart can actually get bruised. If you get hit hard enough, yes, it can bruise it. Does it have perfusion through there? Slightly. It's the same thing as a lung contusion. It's the same thing. Damage to the myocardial tissues may cause an ectopic activity, re-entry pathways, dysrhythmias. We haven't gone over EKGs, cardiology. So these are things that you can see in cardiology. In your EKGs, you will see these findings. Structural changes are rare and often immediately fatal. Signs and symptoms: sharp retrosternal chest pain, soft tissue or bony injury in the area, crackles on auscultation, often an abnormal EKG, ECG. You have your leads on, you're going to see some messed up little wavies. It's not that good. It's not that good. Let's see. Treatment: supportive care, fluid resuscitation, consult medical control before administering anti-dysrhythmic agents. If you have a patient that got hit really, really bad, and they're showing all these weird PVCs, these weird things, contact medical control first. Why? Because that can be an underlying issue of a trauma. So you don't want to be messing with that. You don't want to be throwing anti-arrhythmic drugs to the heart. Those are things that it's caused by a trauma. I don't think the medications will work at that point. Something else happened. I've had this happen with a side-by-side in East Texas. A girl got hit. The ATV landed on top of her, right on her chest, and she was throwing some messed up heart rhythms. And yeah, she had pulmonary contusions and a cardiac contusion. So she had to get flown out. They denied my flight. She stayed in the hospital for I think a day, and then after that they flew her out because it was raining really bad. She had to wait there in the hospital. Acute perforation of the ventricles, atrias. Oh, this is for your. I'm sorry, guys. This is for myocardial rupture. Acute perforation of the ventricles, atria, intraventricular septum, intraatrial septum, choroidal papillary muscles, or your valves. Assessment is patient presents with what? Acute pulmonary edema, signs of cardiac tamponade. Supportive care and rapid transport is your management. We can't do anything. Just treat your patient. Let's go. Treat your patient and let's go. Cardiac arrest caused by a direct blow into the thorax during repolarization. Comial cordis, guys. When somebody gets hit, boom, I've talked about this several times. When they get hit in the chest, perfectly, just in that perfect, something called the R wave. It's that perfect contraction that's going, boom, and they get hit right there in that repolarization stage, that repolarization period. Results of the chest wall, it's gonna stop your heart right then and there. It's going, it gets hit, boom, drop right then and there. You've seen it with football. This last one that we had was the football patient. Unfortunately, everybody watched him collapse. He got tackled, walked up, boom, went down. That's exactly what happens. This is your comial cordis. It's usually what sports where contact with high speed objects occur. Your signs and symptoms: unresponsiveness, apneic, no pulse, cyanotic. You might experience some seizures right then and there. The impact was so hard that it just threw everything shock and went from there. It's pretty bad, but I would definitely look into this. I've had some basic students talk about this. I haven't seen any paramedics yet, but I wouldn't count it out. I wouldn't count it out. I've had a very handful of basic students talk about this, and also cystic fibrosis. Cystic fibrosis. Almost done, guys. Let me see how much more do we have? Ooh. Last one. Current slide. Management assessment of vascular injuries. Your aorta. You already know if your aorta gets hit, oh, there's no coming back from that. You need immediate surgery. Aorta is injured at fixed points by shearing forces. Shearing, remember the shearing with high impact forces, and you have your little linings inside that are like wires. It gets hit, it cuts. It cuts. And this is what shearing does. Impact causes the aortic arch to swing forward and it ruptures. It cuts it, it ruptures. If the okay, we have different layers right here. We have the intima, which is the most inner layer. We have the media, and then the adventitia. So if the intima is torn, blood can dissect along the media, and severe injuries may allow blood to leak from all layers. You have to watch out for these, but the way you can tell is just more right here. Your symptoms may vary. Tearing, pain behind the sternum or the scapula, the back pain, that nasty back pain. Hypovolemic shock, obviously, shortness of breath, altered mental status. Patients going down. You have to pay attention to your signs and symptoms. Know your signs and symptoms. With a hematoma, presentation may include dysphagia, stridor, hoarseness, and difficulty swallowing. Recognition often is suspicion based on the mechanism of injury. Often, no signs of external trauma. Assessment of extremity pulses is important. If you have a pulse that is very tacky here and very brady here, what's going on? Why is one flowing better than the other? What is going on? Expect associated injuries is your multiple rib fractures, flail segments, sternal or scapular fractures, pericardial tamponade, hemothorax or pneumothorax, and your clavicles. Anything that could be associated to a aortic disruption can be right here. Assessment and management of the ABCs. Gradual IV hydration to treat your hypotension. Do not use vasoactive or vasopressor agents. You're going to kill your patient. But how can we know? We just have to go based on our signs and symptoms. But don't use any vasopressors. If your patient is in a very nasty trauma that you can suspect the aortic dissection, do not use your vasopressors. Expedite transport to the trauma center. Remember, we have 10 minutes on scene and we have a golden hour. You have 50 minutes to get to the hospital. Let's get though from there. Your great vessel injuries, protected by bony structures and other tissues, except for the aorta. Injuries more likely to penetrating trauma. Injuries may result in occlusion or artery spasms. Presentation may include your 5 P's: pain, pallor, paresthesias, pulselessness, paralysis. Assessment and management is, if bleeding is not prevented, presentation includes hypovolemic shock, your hemothorax, and your cardiac tamponade. Procedures for acute blood loss: establish IV hydration during transport, treat pericardial tamponade immediately. Assess your ABCs, get your IVs, bilateral IVs, and let's go. Remember, we can't really do anything for pericardial tamponade. Your patient needs a pericardiocentesis. They need that needle up there and then taken out in the hospital, not with us, in the hospital. Diaphragmatic injuries, your diaphragm injuries, occurs in a small percentage of trauma. Most occurs on the left side, where the liver protects the right side. Most of the liver protects that right side for some reason. Recovery inhibited by pressures differences between abdominal and thoracic cavities. 3 phases. You have your acute, begins at the injury, ends at the recovery from other injuries. You have your latent, entrapment of abdominal contents, or obstructive. Abdominal contents herniate through a defect. So you're gonna see some of these injuries where they kind of slip in there, or it goes into other parts. That's where you have your stomach lining as well. So tension, gastrothorax, herniation of abdominal contents into the thoracic cavity, causing pressure to compress the lungs or affected side. Compromised circulatory function as well. Remember, everything is kind of out of whack. Your diaphragm is in the between the intestines and your thoracic. If the middle guy leaves, all those other things are going to start compressing, and it's not good. Most likely carrying the acute phase. Like there, you can see something that's off. Assessment and management with diaphragm injuries. You're going to see your acute phase, which you have hypotension, tachypnea, bowel sounds in the chest. You might hear some bubble guts when you're auscultating, and if you hear bubble guts, more than likely the diaphragm tore. And that's okay. That's completely normal when you have this. You have chest pain, absent breath sounds. Sorry about that. We have our obstructive phase: nausea and vomiting, abdominal pain, constipation, shortness of breath, abdominal distension. Assessment and management. We have your management is going to be just maintain O2, provide rapid transport, elevate the head of the stretcher, positive pressure ventilation. If allowed by protocol, your NG tube. But there's nothing much we can do, just provide ventilatory support, positive pressure ventilation. Esophageal injuries, rapidly fatal injury in the GI system. Signs and symptoms include your pleuritic chest pain, subcutaneous emphysema, associated tracheal injury. These are, if you have something like this, more likely you're going to be calling it DOS right then and there, guys. Assessment and management for these: no specific therapy in pre-hospital setting. Do not give anything orally. We should know this already, right? Tracheobronchial injuries, rare, typically caused by penetrating injuries. You have your high mortality rate. Allows for rapid movement into the pleural space, causing a what? Pneumo. Your physical findings are your hoarseness, your shortness of breath and tachycardia, respiratory distress, coughing up blood, finding of the pneumothorax. You have a messed up lung, you can't hear anything, decreased breath lung sounds. Boom, pneumo, right there. Focus on ABCs, guys. ABCs. BVM, instead of intubation, avoid high ventilatory pressure. On this one, tracheobronchial injuries, just BVM. Remember, the tracheal injury. You don't want to put anything down there. It's going to mess it up. Just ventilatory support. Ventilatory support. And the last but not least, traumatic dysphagia. Induced by traumatic injury that is forcefully compressed into the thoracic cavity. Anybody that gets basically squished, traumatic asphyxia, you will see the line where something happened, causes pressure to major veins of the head, neck, and kidneys, causes rupture within the capillary beds. And you will see, like, let's say for here, you see the line right here basically. Something probably went over here and it stopped everything from going. So this is what it means with the pressure of the major veins, head, neck, and kidneys, the rupture of the capillary beds. All these reds, the bulges of reds right there, that's the messed up capillary beds. That it ruptured everything. It leaked into that space, and that's where you can see it. Physical findings: cyanosis of the head, upper extremities, and the torso. Ocular hemorrhage, everything, the pressure is coming so bad from the eyes that your eyes are going to be bleeding out. And swollen and cyanotic face structures as well, everything. You know those movies where somebody's like getting squished and everything's just popping out? That's what it is. Provide high flow O2 with a non-rebreather. Take cervical spine precautions. Obtain IV access with 2 large bore IVs. Transport to the nearest trauma center if your patient is not already a DOS. That is it, guys. I hope everybody, if anybody has any questions or anything like that, shoot me a message. I'll be helping you out as much as I can. You guys have a good one.